Hello, Calaveras County, and welcome to another episode of Mondo Calaveras. I'm your host, Mike Taylor. Now, today's guest, well, we're just going to stumble all over this part of our bodies. And we were talking just before we started to record the show, and the word dentist might have been frightening once upon a time, but now it's coming into all facets of our health. And my guest this time is Dr. Dave Arnold. Dr. Arnold, thanks for being here.
Pleasure to be here. Nice talking to you, Mike.
Now, as we were talking to start, you were saying that dentistry is changing now to the point where everything, folks who, as we were joking, we used to say the dentist is just the man or woman who tunes up our teeth.
Sure.
But now it's involving everything, and you said mostly we're talking about our airways.
Yes, yeah. It wouldn't be the first thing you would think about when you talk about your dentist or dentistry in general. And, there's connections between oral inflammation and heart disease and diabetes. And so we're beginning to connect. It's called the oral systemic connection,
Okay.
But what's happening here can have an effect on the rest of your body.
Sure.
Because inflammation is the basis of all disease, and the most common place for it is in your mouth.
Oh, okay.
But in today's journals that show up on my desk almost daily, it seems, because I get piles of them I try and keep up with. But it just seems that not a journal goes by without the word airway. And it's just. I don't want to say it's a new buzzword, but it kind of is, because we've suddenly come to the realization that, first of all, the most important thing in our life is our breathing and our next breath. Yeah. But the airway and airway obstruction occurs because of the back of the tongue and the position of the jaw. If we go to CPR, like we mentioned, the first thing you do to open the airway is tip the head back and pull the jaw forward. Yeah. Pulling the jaw forward brings the tongue forward because your tongue is attached right behind your chin. So anything that changes the position of your chin changes the position
will move
of the tongue.
Because the tongue is so much thicker in the back of our
throats. And you've got the soft palate and the uvula back there. Yeah. And that's where restrictions and obstructions occur. So simple snoring is just vibrations caused by obstruction. And then that goes all the way to, there's a lot of new terms, but sleep disordered breathing is one of them, but sleep apnea is the one that people are probably most familiar with. And I treated a patient who had sleep apnea in the mid-'80s with an appliance that brought the jaw forward. Wow. I wish I had patented it or done something.
I was going to say, you were long before everybody came into the...
I was ahead of the curve. But the thing is that I didn't even know what sleep apnea was in the 80s. It just wasn't something that was talked about or mentioned and today I think most people at least have heard the term.
Yeah, or we've seen the commercials for the devices and that kind of thing.
Right. But sleep apnea is when you stop breathing for 10 seconds or more. That's called an apnea. Okay. And that then you can have the shorter term, which is hypopneas they're called, or just simple snoring, and then we can get real serious where we begin to have long periods of time where we stop breathing. And if anybody's got a partner that's got some kind of at least partial obstruction, they're either snoring, waking up the neighbors kind of thing, or you wait for them to breathe. And then they gasp.
And my father had that, and he was notorious for falling asleep in the easy chair. And the big, huge snort to wake up. Right. So you could tell that
those
he had
were
stopped
apneas.
breathing.
Yeah, those were apneas. And when you think about it, maybe you have 20 or 30 of those an hour.
Wow.
And you start doing the math, and let's see, each one of those is 10 seconds, and oh my gosh, you're spending like a lot of time not breathing.
Yeah. And or struggling to breathe. It almost sounds like.
And then what the term obstructive sleep apnea is that you do have the breathing starts. So your breath is initiated. Your brain says, I need to take a breath. So you begin to a breath
pull,
it's basically you're creating a vacuum and you're sucking air in.
Yeah.
Well, and then the air something gets in the way and it gets stuck.
Yeah.
And that's basically an obstructive event. There's also central sleep apneas where the breath is never initiated. Your brain never turns it on.
Oh, so is that more a
well,
neurological situation
it's totally
than it
neurologic.
is maybe a mechanics of...
Yep, exactly. And that's a big difference.
Yeah.
And we always, back when I first started learning about it in the 80s, they were two separate events. One was not necessarily connected to the other. Where now we understand more that these things are connected, that you usually have a little bit of each, mostly obstruction, but throw in a little bit of central because your nervous system is getting messed with without this breathing. So, and when you think about, well, if anything obstructs your airflow, it's going to obstruct your ability to have oxygen in the system. So the oxygen saturation, it's called, is going to decrease.
Starts to decrease.
Right.
That's when we get into trouble.
Right. And some Kaiser, as an example, uses oxygen saturation as their test, for sleep apnea.
Oh, okay.
Because as it drops to a certain level, then, it's okay, that's an apnea because we've dropped from 98% to 91%.
Yeah.
But when you do that, your body is like, hey, something's wrong. I'm not getting enough oxygen here. So it starts sending messages to your heart to send more blood to the lungs to get more oxygen.
Oh, yeah. So it becomes this...
Now you've got more stress, more stress on the cardiovascular system,
isn't it?
right? So it's a systemic thing.
Yeah.
And with dentistry now, and in fact, this journal that's sitting on my desk right now, it's almost they're tasking dentistry or dentists to, hey, you guys, you're the ones that see people more often than anybody does.
Than anybody else, yeah, because
when do you go to the doctor?
When you go to the doctor, and you're usually not going to mention something in here to your doctor
because nobody's asking the questions either.
Yeah,
nobody's asking, do you snore at night? And how many physicians, and I don't want to,
it isn't us against them.
But how many of them ask a mother if their child snores? Because that's just as it's the same event, as an adult, but now you've got a growing child, and so you've got their brain is developing and their memories are developing and there's concentration and focus and cognitive skills.
Yeah.
So all of this stuff is all developing in a growing child that now has breathing disorders.
A problem and isn't getting enough oxygen.
But it's asking the questions because. And that's where, I think we're being tasked more, and I do it because I lecture at UCLA to the residents down there, and I'm telling them, hey, it's on our shoulders to do this.
Yeah.
We need to be on top of this because nobody else is. Nobody's asking
kind of
those questions.
Somebody's got to do it sort of thing.
And
what are we finding is causing the majority of the obstruction? Is it the tongue is just in the way, or is it our jaws get lazy and
we can kind of throw a little bit of obesity into there, and in the child you're talking about tonsils and possible adenoid obstruction, so because you got basically these growths in the back of the throat.
Yeah.
But the obstruction is the position of the tongue. So if you have a jaw like mine, where my jaw is back and deep, then I have a higher tendency for that tongue to be in the back.
Okay.
Because there's less space in my mouth because it's more closed up and back. And because that's every time you swallow and put your teeth together, that tongue goes back there. And so the incidence of occurrence has to do with how a person's built. So there is a skeletal kind of build that's more likely to have it.
Is it kind of a situation where you can look at an X-ray and say, "Oh, I bet this person has sleep apnea"?
If you have the right X-ray.
Okay.
I take whenever I have patients that come in for sleep disorders. I have some physicians and dentists that'll send them to me.
Wow.
And then I make an appliance which brings their jaw forward and holds it there at nighttime. So now we're working on that airway by positioning the jaw in a better place. But there's an X-ray that we take routinely for those patients, and in orthodontics, that's a side view of the head.
Yeah.
And so it's two-dimensional, but you can very clearly see that airway. And you can see the uvula, and you can see the back of the tongue, and then the back wall of your throat. And so that's where the obstruction occurs.
So it almost sounds like we don't need those 24-hour sleep studies as much as we did.
Well, it's
or do
very
we?
interesting you asked it. Yeah, that's the gold standard. I mean,
okay.
It really is. Okay, I mean, if you want to really see how somebody's sleeping, that's the thing to do.
Yeah.
But the problem has been that you got to go to some foreign
It's not really a
place.
natural place to go to sleep.
No, not even close.
Yeah.
And then they tape a bunch of stuff to you.
Yeah, you're the bionic
a
man.
bunch of wires, and then say, okay, go to sleep now, and we're going to monitor your sleep. Exactly.
Yeah.
Exactly. So, but there are units now, and I was just looking at one the other day, where a person sent home with
nice.
with instructions on how to tape a thing here so you can get the heartbeat and attach something to the finger so you can get the oxygen saturation. And those units are becoming more and more available.
Oh, that's cool.
And I was like really pleased that, and I was just showing it to my office manager. I'm going, hey, we got to look into this.
Yeah.
Because there's a certain cost from my end and there's a certain cost from the patient's end. But they get to do it at home. And to me, it's like, that makes all the difference in the world.
That's where you're really going to go to sleep
You're
and
going to get a clear picture.
And get the best sleep that you're supposedly going to get. Yeah.
And so that's, to me, is more valuable in really getting a clear indication of what the sleep problems are. But it's so interesting that here we are, I'm a dentist, and we're talking about sleep, and we're talking about breathing, and things are changing. Things are changing, and I'm happy for it because finally we're starting to merge with medicine, and it's merging around our sleep and our breathing, and that's huge.
Well,
for
and you knew
everybody's
this
health.
was going on back in the 80s, it sounds
I didn't
like.
know what the heck it was.
Yeah.
I had this patient that came in, and she had been diagnosed with sleep apnea, and she had
a little
been
bit
to,
of what's
she'd
that?
been to,
Because
exactly.
in the
So
80s we weren't talking about
right,
it.
and so she had been to Stanford, and
wow.
and it was the only sleep center west of the Mississippi River at the time.
Oh gosh.
And they had diagnosed her with sleep apnea. She had fallen asleep driving her car.
Oh, man.
I mean, the stop sign kind of thing, and fell asleep. So, well, that's not good.
No.
And she bumped into somebody else, and so that was how it all got.
Yeah.
So she came to me, and they wanted to do surgery. They wanted to reduce the size of the back of her tongue, and they wanted to cut a part of the soft palate. And so she had all this written down for me, and she said, they want to do surgery. It's in my mouth. You're my dentist. What do I do?
What can we do?
And I'm like, oh my gosh, she nailed me.
So she kind of forced the issue,
right.
but in a good way and in the perfect
right.
patient way.
Right.
And so
but it really was. She was right on it. I mean, I'm her dentist. It's in her mouth. Wow, I better learn something about this.
Interesting that the doctor didn't. None of the Stanford physicians picked up their phones to speak with her dentist.
Yeah,
Have you noticed anything?
Well, it's an interesting story. Because I ended up making her an appliance. I made it. I didn't know. Well, I kind of knew what I was doing, but I was making appliances that were coming out of Germany at the time for orthodontics to bring the jaw forward instead of using headgear to pull things back.
Oh yeah.
So I was trying to figure out a different way to do it. And so there was no internet, you don't just
that's
get on,
the other thing
Google
that
it,
we always forget today is that
I had to go to a library.
It's a
and
look
place where
through
they
the
have books.
encyclopedia and oh my gosh.
Yeah, so I did. I went to UC San Francisco and I went to the library and there really wasn't much, but as I was going through things, I kind of realized, it all has to do with jaw position. And I made this appliance. She went back down to Stanford and was tested, and her apnea was gone.
Oh my gosh.
Yeah, well, they didn't buy it. I mean, I got a nasty letter from the chairman down there. Who,
oh man.
Yeah, and this is a huge name in the world of breathing and sleep disorders and so on. And I got a really nasty letter saying you're giving her false hope, and why are you doing this? And she needs surgery.
Did you send him a nicely worded letter back that said, explain to me why her apnea went away?
Exactly. I sent back the results and said, well, just what you said. So she was a neat lady, and so I said, well, this is what they're saying. You still need the surgery, and I'm not going to refute too much,
Yeah.
but I'm refuting it.
Yeah.
And so she said, well, and they said there was something with the equipment. I mean, because this is not possible.
Yeah, this hasn't been tested. It
Right.
hasn't been.
So
Yeah.
she goes, well, I'm going to tell them to do it again. So she tramps back down to Stanford. I was in Walnut Creek at the time. And she told them that she wanted the test done again, and they did it, and it had zero apnea, none.
Wow.
So, you know, I think of it back. Look back at it now, you know, and I think, geez, you know, I know I was one of the first people to do this, and now there's a lot of these different appliances.
Well, I was going to say, have you noticed in these appliances that have been developed now?
Right.
Have they duplicated what your appliance was done?
Yep, exactly.
The one that you jury-rigged?
Yeah, I mean, they've played around, and, you know, the things are a little more sophisticated maybe, you know, with materials. Now materials are so available, and the strapping that you use to keep the jaw forward. But I just made it up, and it was just this little jig that I made, and she wore
almost
it at
like a
nighttime.
retainer,
Yeah,
for lack of a better word?
but there was a top and bottom place for her teeth.
I see.
That her only way for her lower teeth to close, she had to bring her jaw forward. Right. And held it there.
Does the body then kind of naturally sort of start to pull the lower jaw forward?
There is a pressure that you're creating, and it's being on the teeth, because you got to use the teeth as your vehicle to hold the thing in there. But you know, I do take X-rays, and I examine, you know, jaw function and so on, because I want to be sure we're not stressing the system too much, because we are stressing the system.
Yeah,
we dream the jaw forward for maybe 6 hours or 8 hours at night, and there is some potential changes that can occur, but we're real careful in monitoring it. I mean, there are some changes that can occur that we really don't want. We want the jaw to go back to its original place during the day, so you can chew and you can function and then do normal things. But that's just part of the process, you know, is to just make sure the evaluation is thorough, and that the appliance is acceptable for that person.
Is there a small percentage of patients who might get one of these devices and it doesn't help their apnea? And then where do we go from there?
Where do you go from there?
Yeah.
Well, to answer your question, yes, there are people, and I try and diagnose it such that we're not putting something in and not working. I want to have an idea it's not going to work beforehand.
Yeah.
Because there's certain ways that people are built that it just doesn't work.
Okay.
I mean, the jaw just doesn't come forward very easily, or they've got a TMJ problem. The joints are compromised, and so you can't stress that system. So you go back to the gold medical standard, which is a thing called a CPAP. A CPAP is continuous positive airway pressure, and it's a mask basically that pushes air into your bronchial tree, and they put enough pressure in that the pressure backs up, and so it holds the pipe open, you know, kind of thing.
Okay.
That's how it works. It just creates a positive pressure in there so that the airway cannot collapse. And that's the gold standard in medicine. I mean, that is what they use, and it works. I mean, it just flat works. You can, if it doesn't work on this pressure, you just turn it up.
Oh, really?
And you can get enough pressure in there that airway will not collapse.
Now, is part of that pressure that mask clamped to your face?
Well, yeah, there's that. I'll tell you, the biggest problem with the CPAP is people wearing it, because it's not very sexy. There is a little pump mechanism.
That's kind of purring through the night.
Yeah, and it kind of comes down and goes over your nose and your face. And so there's some issues with people just not being compliant with it.
Yeah.
But I'll tell you, if you've got somebody that has severe sleep apnea, I mean severe, where they really, they can't stay awake during the day.
Yeah.
They wake up and they're tired, and they got a headache, and you put one of those things on them, and you can't take it away from them, because it changes their life. It really absolutely changes their life.
What do they experience? I mean, they wake up the next morning and they feel great.
They feel good. They feel energy.
They actually slept.
They can do things during the day. It literally changes their life.
Wow.
Yeah, and now the appliances that I'm talking about are FDA approved for mild to moderate sleep apnea, But oftentimes you get the same result. I mean, people wake up and they're just, oh my gosh, this is how you're supposed to feel.
Wow.
Yeah, it's really, it's very satisfying to
I
see
bet.
people, all of a sudden realize what a good night's sleep is.
Do you have some patients who are surprised that they got their answer from their dentist?
Oh, yeah. Oh, absolutely. Yeah.
Because you think, I'm not dealing with my teeth,
Right.
so I should be seeing a medical doctor.
Right.
For whatever's going on back here or down under here.
No, it really is true.
Yeah.
And again, I think it's just that the dental field is expanding,
Yeah.
and I hope that includes all dentists. That they're all looking at these journals and they're all reading these things that are we need to be asking questions and asking people about their sleep or do you snore and looking in the back of their throat rather than just at their teeth.
Yeah.
And having them say and looking back there, because if there's irritation and there's apnea or snoring, it looks irritated back there. But you got to look.
Yeah.
And that's, again, I think we're being charged with doing that. I mean, taking it on our shoulders as dentists to not stop at the teeth, but to look at the soft tissues and feel the glands and look in the back of the throat and because there's more than teeth in your mouth. Teeth are only 25-30% of your mouth.
Yeah, that's true.
And the rest of it is all stuff that we're responsible for too.
Have you noticed that the medical community is more accepting of the dental community's inputs on this than they were back in the 80s?
Oh my gosh, yes, absolutely. And it's it is a team thing. I mean,
so it is becoming that crossover.
Yeah, it's getting better. I mean, I can't say it's that we're talking to each other as much as I think we should or we could be.
Yeah.
But it's better. It certainly is better. I mean, we're really
good
starting to, I think, make it more that we're responsible for the whole person. You know? And it's not just teeth and it's not just systems, from the medical side. We're meeting in the middle. And we're looking at things better.
Are they still moving with some patients toward the kind of surgery that they had suggested that your patient back in the 80s might get?
Yeah.
Or does the CPAP kind of prevent that and it kind of saves us?
There still is a school that looks at those surgeries. I mean, and it's more, it's not reducing the back size of the size of the tongue is pretty extreme. And I haven't seen anything of that. But there's a surgery, it's called a uvulopalatal pharyngeoplasty, but what they do is it's the soft palate, the uvula that hangs down the back of your throat. They trim that back.
Oh, really?
In order to make more space.
That little tiny thing gets in the way that much?
Oh, yeah.
Really?
Yeah. Well, it's what it's attached to. Your soft palate, when you go back, there's a hard palate, and then there's a soft palate and the uvula that hang down basically in the back of your throat. And it's the tongue pushing against that tissue that then goes against that back wall and plugs it up. But the soft palate's kind of important because without it, when you swallow, your soft palate lifts
to
and
prevent
keeps food
stuff
from
going
up
into
in your
your
nose.
sinuses.
Right. And so the problem with those surgeries sometimes is they're trimmed a little too much, and that can be, you can get some regurgitation basically of food and fluids into your nose.
So it really does sound like we've finally realized it's a completely systemic thing.
Yes.
Just chewing on something and swallowing it is, and
I'll
joke with you, when I was a kid and you were eating and you cough or choke on something, my mother used to always say, something went down the wrong pipe. So as a child, I thought, somewhere in here there's this valve that says that's air, that's food, that's air, that's food. But it sounds like that there's a little bit of that really going on.
That's exactly right. I mean, that is exactly right.
Even though it's all going down the same pipe.
Right, but it's called the epiglottis, and the soft palate has to lift for food to go by this way so it doesn't go north. And then as it comes down, it crosses over, and then this flap closes to let the food go by so it doesn't go down the wrong pipe.
Man.
But the pipes are right there, and there's a little flap. And
Yeah.
that was well described because that's exactly what it does. Our bodies are amazing.
I was just going to say that exact thing. Our bodies were designed this way for a reason.
It's pretty cool. It really is pretty cool.
Dr. Arnold, we're down to our last 3 or 4 minutes, and I just want to ask, what else is kind of new and exciting and different in dentistry these days?
You know, I don't want to be critical. I saw it just when I was leaving the house. There's it's called the Smile Design Club, where you can get your own little aligners, like Invisalign kind of thing, by mail. And I just had a patient come in that has done that. But my question to her was, did they look at your TMJs? Did they examine your jaw? Did they look at your gum tissues and bone and root support? And they didn't do any of that. And that scares me.
I wondered about that when I first saw that style of commercial. It was like, well, wait a minute.
Yeah.
You know, it's kind of like WebMD, you know, Dr. Smart, who we do shows with here.
Sure.
He always says, you know, I would almost prefer people didn't go near the internet when they're exploring their symptoms, because they always start piling on.
And then they get those symptoms because it's like, well, I think I have that.
Yeah,
you know? And I think.
And then they walk into the doctor telling them, oh, I have this.
Right.
And so, that's interesting.
But that's worrisome to me.
I would think so.
Yeah.
You've got to look at the system. I think
you got to have somebody really taking care of, somebody who's in charge of the treatment.
Yeah.
And I don't see that with that.
And that can't be somebody virtual. That needs to be somebody who you go visit.
Right.
Who looks at the X-rays.
And then probably another question I get a lot is, I see this clear choice where they put implants in and teeth on the same day. You know, you walk out with these new teeth on implants. And in theory, yes. I mean, it's you can put implants in, and I've done it with our surgeon here. And then there's a temporary set of teeth that is attached to it. But you're not walking out with your final product. I mean, not even close.
Yeah.
And you're on a liquid diet for about 3 months. But there's a lot of things that aren't said, and people have questions, and that's probably, those two things are probably most of the questions that I'll get. I mean, people just wondering, well, I saw, you know, you can have your teeth taken out and implants put in, teeth on the same day. It's like, well, that's a little bit of an exaggeration.
I remember when I had my lower wisdom teeth pulled, and I didn't want my jaw touched for a couple of months after that.
Oh, yeah.
So I can't imagine somebody thinking all of that's going to happen magically on one day.
And it can all heal like that without you know, some period for the implants to integrate to the bone. And
we don't quite have Dr. McCoy yet, just waving his magic instrument over you to make you well.
Magic wand isn't there, man. It's
not
just not there. Healing is healing. It's just the way it is.
That's it.
Yeah.
Well, so as usual, Dr. Arnold, thank you so much for being
really enjoy
here.
Talking to you.
You bet. I enjoy having you here, and I hope our viewers do too. So, folks, when you're having problems sleeping, don't just talk with your doctor. Talk with your dentist too, because he or she may be able to help you out a little bit more initially than maybe your traditional physician can. So yeah, you're brushing and flossing every day, right? And you're keeping those teeth healthy, but let's keep the airway healthy too. Until next time, I'm Mike Taylor. Enjoy.